Hello, and a very, very warm welcome to everybody to today's Noma Research Day. My name is Marianne Comperet, and it's my greatest pleasure and honor, in fact, to welcome everyone here today on behalf of Médecins Sans Frontières, the International Society for Neglected Tropical Diseases, as well as the countless partners that have come together today for this very unique and important meeting. Now, this Noma Research Day builds upon some already incredibly positive meetings and renewed momentum that have happened over the past 18 months or couple years. And in fact, many of you probably attended and even spoke at some of these past events, which brought together a whole range of energies and approaches, whether they were in the format of a conference, a webinar, a film screening, etc. And it's safe to say that conversations and advocacy around Noma have in many ways and diverse forms really stepped up recently. And not to mention beyond that, of course, really standing on the shoulders of giants who have been tirelessly working to understand, inform and advocate for this disease and those affected by it for quite literally decades. And all that from the grassroots level all the way to the high level global organizations. So the great news is that today, and I do hope that you share this feeling as well at the start, on this very first Noma Research Day, it does start to feel like we're pushing against a slightly open door that can lead to many paths. However, despite this renewed momentum in advocacy, despite more and more people hearing about and coming on board with the glaring neglect of Noma, the time is now right to hone in a little bit more on the technical case for Noma and really to start thinking in very precise terms and strategically about which gaps need to be filled to make sure that Noma rises through the global health agenda and receives the resources and the support that it truly requires and deserves. So today is shaping up to being a really unique and exciting event. In fact, I would even say it stands to be a real catalyst of a meeting. Over the next few hours, we will have the opportunity to hear about research in the field of Noma from colleagues around the world, both completed and ongoing. There'll be plenty of chances to ask questions and engage in conversation. We will also have a roundtable discussion, but today is really about our speakers and our presenters, and it's really about you as well. So we do want this to be a really interactive meeting, despite our constraints, it being online. Please, by all means, if you haven't done it already, add your name, your country, your organization in the chat function. For those of you who would like interpretation, I'd like to remind you there is also a separate area where you will have simultaneous translation in French by Claire and Thomas, if that's of any help to you. And in general, we just really want you to be involved, ask questions, share your own experiences, and we will really try and bring all this together. Without any further delay, I'd like to open this meeting and I wish for everyone to have a very productive discussion because all of this really today is to get a good sense of where we are in terms of existing research and gaps, but also, and all importantly, to better understand by the end of the meeting, a future vision for Noma research and how we can all contribute into strengthening this. So on this note, I'd like to introduce our first speaker. It's my pleasure to welcome Dr. Yuko Makino to the discussions to open our day. Dr. Makino is Technical Officer at the World Health Organization's Regional Office for Africa. Dr. Makino is one of those giants that I referred to who has been working incessantly to make sure that Noma at the highest levels at WHO is recognized and is supported and advocated for. And first and foremost, please welcome Yuka with a presentation on the very recent WHO's oral health resolution, paving the way forward to fight against Noma. Thank you and a very warm welcome.
Thank you very much for your kind invitation to this important Noma Research Day. Today, I'd like to talk about WHO's oral health resolution paved the way forward to fight against Noma. First of all, I'd like to review what is Noma. Noma is a necrotizing disease, destroy the mouth and the face. In the absence of treatment, Noma is estimated to be fatal in 90%. However, if Noma is detected early, the progression can be rapidly stopped. It mostly affects children between 2 and 6 years old suffering from malnutrition, living in extremely poverty and with weakened immune system. Therefore, Noma is called the face of poverty. Because of the rapid progression and the high mortality rate, numerous cases remain undetected. Now, mostly is prevalent in sub-Saharan Africa. This slide shows the key milestone of global and regional Noma control program by WHO. Since the inception of WHO global program to control of Noma in 1994, the WHO oral health program has led global and regional Noma control efforts, including implementation of the regional Noma control program in Africa since 2001, providing technical and financial support with 10 Noma priority countries in Western Africa to develop and implement the National Noma Control Program since 2013, producing the technical guidance document and facilitating the discussion on Noma in the WHO decision-making body. WHO has encouraged countries to take more integrated approach for preventing and controlling oral disease, including Noma, because oral disease are caused by a range of risk factors and underlying determinants. These risk factors and determinants are shared by other conditions, such as non-communicable disease, NCD, and neglected tropical disease, NTD. Therefore, WHO has encouraged countries inter-multisectorial collaboration to take a more integrated approach to fight against Noma, including facilitating the integration of Noma control into NTD program at the operational level. Another key important milestone is the oral health resolution in 2021. In this May, during the World Health Assembly, the decision-making body of the WHO, the oral health resolution was proposed by 42 member states, countries, discussed and endorsed. WHO resolutions are important political documents which upgrade WHO mandate and influence resources. Since the last resolution on oral health in 2007, oral health, including Noma, had not been discussed in the WHO global decision-making bodies such as World Health Assembly. Consequently, the lack of political commitment and resource limit action on oral health. I'd like to draw your attention to the comment by the Director General of WHO, Dr. Tedros, after the adaptation of the oral health resolution. Oral health has been overlooked for too long in the global health agenda. 14 years after the last consideration of oral health, this resolution provides a welcome opportunity to address the public health challenge by oral disease to reposition oral health as a part of the global health agenda in the context of universal health coverage. This resolution calls on countries' action and also requests WHO's action. You can find detailed information on this resolution in the WHO website. Today, I'd like to emphasize member states, namely countries' request to WHO in this resolution, especially related to Noma, which is highlighted in the orange box of this slide. Member States request WHO to include Noma in the upcoming review process for the WHO NTD list planned for 2023. As a result of this, Noma should be included in the roadmap for neglected tropical disease. What does it mean? Indeed, at the political level, it has been discussed that Noma should be included into the WHO NTD list because Noma affect vulnerable populations who do not have a political voice to advocate for this issue. In addition, integration of Noma into the WHO NTD list may help reverse the current situation. Noma still benefit very limited attention by national health authority, research institution, and being neglected by international development and health agencies. From next slide, I'd like to mention the way forward to include Noma into the NTD roadmap. In this beginning of this year, the roadmap for neglected tropical disease was launched, covering 20 neglected tropical diseases, which are in the WHO NTD list. This roadmap set global targets and milestones to prevent, control, eliminate, or eradicate 20 diseases and disease groups, as well as cross-cutting targets aligned with the Sustainable Development Goals. Broadly, this roadmap is expected to encourage three fundamental shifts in the approach to tackling NTD. Firstly, increase accountability for impact by using impact indicator instead of using process indicator, and accelerate programmatic action. Secondly, move away from siloed disease-specific programs by mainstreaming programs into national health system and intensifying cross-cutting approach centered on the needs of people and communities. And thirdly, change operating needs and culture to facilitate greater ownership of a program by countries. So, how to integrate Noma into the WHO NTD list and include Noma into the NTD roadmap? Any inclusion of additional disease into the WHO NTD list should be requested by one or more member states and submitted to WHO NTD department. The request should be accompanied by a dossier to justify how the disease meets the suggested criteria, such as disproportionately affect population living in poverty, primarily affect population living in tropical and subtropical areas, amenable to broad control, elimination, or eradication by applying one or more of the 5 public health strategies, such as preventive chemotherapy, intensified case management, vector control, veterinary public health, and safe water sanitation and hygiene. And the final criteria is neglected by research. Indeed, WHO is now conducting the gap analysis to demonstrate whether Noma meet the inclusion criteria of the WHO NTD list. As a part of this gap analysis, I'd like to introduce the summary of the result of a systematic review of the evidence-based knowledge on Noma, jointly conducted by WHO and the Infection Disease Data Observatory. This systematic review included 293 studies from 65 different countries between 1939 to 2019. This map captures the spatial distribution of Noma study from 65 different countries. According to this review, 74% of the study were case report or case series, and only 5 interventional studies were identified. 190 unique potential risk factors were identified, and a total of 317 unique interventions were reported. This indicates substantial heterogeneity in reported risk factor and intervention. There was also a large variation in the quality of evidence provided by primary source in terms of estimate of incidence and prevalence reported. Therefore, need more prospective interventional study, the standardization of the definition and diagnostic methodology, as well as standardized treatment guidelines of Noma are required. This is a key take-home message. Oral health resolution provides the welcome opportunity to address the public health challenge posed by Noma as a part of the NTD roadmap. Following member states' request to WHO in the resolution, one or more member states need to request including Noma in the planned WHO 2023 review process with a dossier. The systematic review highlights substantial knowledge gap and severe lack of high quality and comprehensive study. The global Noma community needed to prioritize the documentation its burden and delineation of effective strategy and intervention to prevent and control Noma. Thank you very much for your kind attention.
And thank you very much to Dr. Makino for this really excellent and encouraging overview of all the hurdles that Noma has been able to overcome, really giving us a lot of food for thought, drawing from the oral health field, but also the neglected tropical disease field. And I'm sure you've given us a lot of material there to our fellow speakers, but also to all the participants tuning in today to really frame their research and think about those important collaborations going forward. And perhaps at this stage, I would just take a few seconds to greet some of those that have joined us. We've got an incredible and amazing international audience. And so just before we take any of your questions for Yuka from the chat function, say a very quick hello. We've got Nancy Gordon here tuning in from the University of Buea in Cameroon. Hello and welcome. Welcome to Sophia Thomas from the Public Health Foundation of India. Mohana Amita Raja, MSF Amsterdam. Hi. Fernando Hugo from the Federal University of Rio Grande do Sul in Brazil. Anna Gina, Anasvat Foundation. We have Katja Seeling from Germany. Bit closer to home, lovely to see Mark Ide from the Faculty of Dentistry, Oral and Craniofacial Sciences at King's College here in the UK. And a special hello as well to our friends and colleagues at the Noma Children's Hospital in Sokoto. Hello, Adeniyi, Semu Adetunji, lovely to see you tuning in today. And many, many more of our colleagues, please do continue to send us your greetings and say hello in the chat. And all importantly, post your questions, please, any comments for our speakers, and I will endeavor to, first of all, find them. Okay, no questions so far, that's perfect. And also make sure that they are posted to our colleagues throughout the day. So Yuka, after these warm hellos to everyone, I just wanted to thank you very much. And obviously, being from the neglected tropical disease kind of field, it was really interesting for me to hear how you're drawing on all these different sectors to make sure that the advocacy for Noma really moves forward very quickly now with some very important and really concrete deadlines over there. So the first thing really that I think would interest many of our colleagues, many of whom are researchers in neglected diseases in general or in oral health, is you've mentioned, so the WHO NTD roadmap. That's been a really important piece of policy kind of framing that came out earlier this year. And so although it's aimed probably more on a programmatic level, I was wondering if you could give us a bit of inspiration or some thoughts as researchers, how to align maybe future research on Noma to the three really important features of this roadmap to 2030 on neglected diseases. And those three features being that future approaches to neglected disease should focus on results rather than processes, should also really be very cross-sectoral in terms of their outlook, and finally should involve and concede ownership of the approaches to local partners, to researchers in endemic countries. How can we adapt our Noma research to really fit this brief and therefore to align very nicely with the movement in neglected disease as will be ongoing to 2030?
So first of all, thank you very much for Marianne for facilitating this very important research day, and also congratulations for this organizing this wonderful event. So yes, as mentioned that this roadmap is actually shift towards more with outcome oriented and also cross-cutting approach and also ownership of program. And especially I'd like to emphasize about like a cross-cutting approach or and the partnership issue, because I think the one of the important issue is not like approach for the silo, more cross-cutting and holistic approach. Therefore, for the research sector, I just would like to maybe emphasize 4 points in order to emphasize or like leverage the cross-cutting collaboration. For example, as you know that it is quite important to collaborate with NTD team, especially some similar diseases such as skin NTD, and then it is needing more collaboration work and obtain the lessons learned from these skin NTD disease team. And also potential risk factor of Noma such as malaria and immunization or HIV/AIDS, that collaboration also quite important to accelerate the research. And also another collaboration would be the partner of nutrition and water and hygiene and sanitation, especially as mentioned that 5 public health strategy to amenable to control the NTD. One of the intervention is actually safe water, sanitation, and hygiene. Therefore, this area also quite important. And moreover, I just would like to emphasize for the early detection and diagnosis. WHO has just recently launched the project called M-Oral Health Program, which try to leverage mobile and digital technology to promote oral health. Then one of the components of this M-Oral Health Program is MRE detection. So utilize mobile technology to accelerate early detection. So as I understand, Skin NTD team has already developed the app to facilitate detection and diagnosis of skin NTD. Therefore, the collaboration with this digital technology field also quite promising. I hope I answer your question. Over to you, Marianne.
Absolutely. Thank you so much, Yuka. And we will be having a round table later on today. We do have a representative from NTD NGOs working on kind of cross-disease collaboration on skin. So these are absolutely areas to watch. And as you yourself were saying, one of the big take-homes of your presentation was that we really need to standardize this diagnosis, need to standardize as well approaches for treatment. So thank you for guiding us in the right direction. And moving from the research a little bit more to the advocacy framework, you really clearly explained, thank you, the process for member states themselves to request for a disease such as Noma to be added to the list, the official list of NTDs, as and when appropriate in the WHO's internal workings. I just wanted to ask you, since you obviously have the WHO experience and we have a very captive audience and international audience here, what is it that those tuning in today and listening into this message could do kind of at a more community, grassroots, or within academia, at that level? What can we do in order to, at the higher level, WHO level, ensure that those member state representatives really take this cause forward? Are there practical actions that we could do to support this effort?
So thank you very much. I think this is a very, very, relevant and like an important question, because I think today's Research Day is a definitely great opportunity to provide a platform the stakeholders join together to discuss Noma issue. So I think, it would be great if Noma stakeholder can also create the collaboration platforms such as, coalition of Noma. For example, now I'm working in African region, and then we have a program of the sickle cell disease. And actually the stakeholder developed the coalition of the sickle cell disease. Therefore, maybe it would be great to develop such coalition among like a stakeholder, researcher, and also like a NGO to tackle Noma issue, to take more integrated approach in action on Noma towards this 2023's reviewing process of the entity list and also beyond. Over to you, Dr. Marianne.
Thank you. We've had since a question here from Professor Mosi in the chat. Thank you, Professor. And Professor Mosi was saying, it's maybe an obvious question, but excuse me, why is the allocation of resources so disproportional to the problem? Is it the lack of access to the oral health expertise, or are there other barriers? And this slightly ties into a comment and a question by Philippe Rattler, who is asking, I'll try to translate as best as I can from French, and why is it that the WHO themselves have mostly framed for the last 20 years or so this as a oral hygiene problem? So have there been barriers in the past, and what will be changing, Yuka, going forward?
So I think maybe I could not catch up clearly the second question, but in terms of the Professor Mosi's question, hello, Professor Mosi. I think, as mentioned, that oral health itself, including Noma itself, is actually neglected. And as mentioned that, for example, since 2007, oral health agenda has not been, discussed in kind of like, really, high level political level, such as World Health Assembly. But after like 2011 in the UN high level meeting in the NCD, and then 2019 in the UN high level meeting on the universal health coverage. At that time, oral health was included in that final product of a document, as well as the establishment of like a Lancet Commission. And then like I think keeping like evolving the momentum of the oral health and Noma. And then finally, as mentioned, that this year oral health resolution was adopted. As mentioned that this kind of a political document is actually the really important to upgrade the mandate of WHO and also resource allocation. Therefore, hopefully, this historical resolution, bring and like make a difference for situation of like a resource, as well as a more prioritize the oral health agenda in the global health field. I hope I answer the Professor Mosi's question. Over to you, Marianne.
Of course, thank you, Yuka, and also Mathis Winkler. Many of you will know Mathis, head of projects at Hilfaction Noma. Hello and welcome to the meeting. Mathis is added in the chat. I'd say it's also lack of interest by many governments to shed light on a disease that's essentially a manifestation of malnutrition and lack of hygiene, and the fact that most victims are hidden by their families, never brought in for treatment. Good point, Mathis, and if anyone else would like to comment, and please, by all means, go ahead and continue those discussions in the chat forum. We just have time for one quick last question, which was asking you, Yuka, a little bit more about what you mentioned in your presentation. Helen Hernandez, hi Helen, is asking, I'm curious if there were any observations or trends you can comment on from the 200 or more case studies, were most related to surgery, diagnosis, underlying cause, etc. And were there any shifts over time that you noticed as the research evolved? Thank you.
Thank you very much. That is very, very important question. So in terms of that, because I mean, Professor Hayden would like to know about like a time trend. Is my understanding correct? What shift between, I mean, like, so for example, according to this systematic review, we can definitely notice the change of the geographic and spatial distribution, because I mean, like around the 1980, we also have a case in that, I mean, some of the current higher income country, but now move to more in the, I mean, African region. For example, I mean, I cannot specifically mentioning about like, I mean, how the spatial distribution changed over entire around the 150 or more than 170 years. But yeah, definitely the geographical distribution was changed.
Brilliant.
Yep.
Yuka, thank you so much. There's been, of course, more questions, more and more questions. You've given us so much food for thought. Perhaps we could hold on some of those for later discussions, or Yuka, feel free to join in on the chat if anyone has any replies for Semyu as well as Anna. And so without any further delay, I'd like to thank you, Dr. Makino, for all your thoughts and insights today. And we're going to build on what you said and now turn to a very exciting part of the day, which is when we're going to hear a bit more about the actual research that's been done in Noma, both completed and ongoing. There was a call for abstracts that was put out earlier this year, and with lots of really interesting and exciting responses. And so for this first part, we're going to hear from 4 researchers who have sent in a presentation on their completed research, spanning kind of a range of topics and themes around Noma. So I'd like to very warmly hand over now to our researchers. We're going to hear from Dr. Basil Ojukwu, Dr. Esther Erommonsele, Alice Trotter, and Victor Oluwalomola. So thank you very much for your contributions and for sending in your research. And over to you, first and foremost, Dr. Basil Ojukwu, and we will be hearing about your research on a 5-year review of Noma cases managed at a tertiary hospital in Northeast Nigeria.
I'm Dr. Ojukwu Basil from the Department of Public Health, Intercountry Center for Oral Health, ICO, for Africa, Jos, Plateau State. I shall be doing a 5-year review of cancrum oris cases managed at a tertiary hospital in Northeast Nigeria. My co-authors are Dr. Thomas Owobu, who is the head of Dental and Maxillofacial Surgery Department of the Federal Medical Center in Guru. Others are his doctors and co-workers at the center. We all know what Noma is, but one important aspect is that it's an opportunistic infection that affects malnourished children and immunocompromised adults and elderly. And environmental factors and socioeconomic factors play an important role in the pathogenesis of this disease. The Northeast Nigeria, which is the study environment, had witnessed armed insurgency for over the past decades, which has caused mass displacement and migration of people. And the environment where they are displaced had attendant health and socioeconomic consequences. Noma disease from this region has been underreported, and little has been seen from the literatures of Noma cases in this region. So we decided to do a 5-year review of Noma cases managed at a tertiary hospital in Northeast Nigeria. A retrospective study was conducted at Federal Medical Center in Guru, Yobe State, Nigeria. Patients diagnosed and treated for Noma between January 2017 to July 2021 at the Dental and Maxillofacial Surgery Department of this hospital were retrieved from the hospital record, and patients' data were extracted by 2 trained dentists using a study pro forma. Case files with insufficient records were excluded. Data retrieved were the social demographic variables, the year of patient's presentation, the diagnosis of Noma using WHO staging of Noma, simplified oral hygiene index by Grimm and Pemilon, treatments given at the center, and treatment outcome. Patients were categorized into children between 0 to 16 years of age, adults 17 to 59 years of age, and elderly greater than or equal to 60 years for ease of analysis. The data retrieved were analyzed using SPSS version 25, and Fisher exact tests were used for association, and p-value less than or equal to 0.05 were considered significant. Ethical approval was also received from the ethics committee from the Federal Medical Center in Guru Yobe State. We were able to retrieve 49 cases, and out of that 31 cases met the inclusion criteria, which represents 63.3% of the records retrieved. Found that more female were among the patients seen, and the age range were between 2 to 65 years. All patients that presented with normal cases had poor oral hygiene status. The children accounted for 67.7%, and the peak year was 2018, with 35.5% of cases seen. Among the cases seen, stage 2 Noma was prominent, and stage 4 follows. Association between gender and the stage at which the patient presented was not found to be significant, with a p-value of 0.71. Also, the association between the age group and the stage of disease at presentation was not also found to be significant. We found out that out of the 31 cases seen, 51.6% of them were discharged because they presented at early stage, but a significant amount, 48.4%, were referred, but there was no follow-up to know whether these patients referred to the Noma Children's Hospital Sokoto actually got there and what was the treatment outcome. We also found out that there was a significant association between number of patients seen and then the treatment outcome of this patient. Children were mostly affected from the study environment, and this correlates with other reports seen by other researchers, such as Nwunwu et al. An early presentation had better outcome, which was also reported from the same study environment and other researchers. And we found out that there were lots of data that were lost because of misdiagnosis, poor documentation, and which correlate to findings from a researcher from Zambia among rural health workers with suboptimal knowledge in diagnosing and management of Noma. Hence, lack of such knowledge represents a barrier in managing Noma, especially at early stage. In conclusion, children are a vulnerable group to this disease. Poor oral hygiene status was a common finding, and better treatment outcomes were achieved on early presentation of this disease. It is important that we increase this disease awareness and surveillance for early detection, treatment also with emphasis on children. Secondly, there's need for retraining and training of oral health workers, not only dentists and dental auxiliaries, but other health workers, community extension health workers and others, on oral health promotion, disease identification, referral channels, proper case documentation, because from the study environment, we've lost a lot of data because of poor documentation. Improving this knowledge among these health workers is one and very crucial way to prevent the development of this disease. There was no conflict of interest, and I must appreciate the staff of Dental and Maxillofacial Surgery Department of Federal Medical Center, Guru, Yobe State, Nigeria, for their efforts in contributing to the success of this research. I appreciate you all. These are my references as displayed on the screen. Thank you for listening.
Good day, everyone. I am Dr. Esther Erommonsele from the Department of Community Medicine. I'm in the Kano Teaching Hospital, Kano State, Nigeria. And I'll be presenting on the paper, Attitude and Knowledge of Early Career Dentists on Noma Management in a Tertiary Institution in Northern Nigeria. This study was carried out alongside with senior colleagues from the Department of Oral and Maxillofacial Surgery, and we would be using the following outline. Okay, well, as we all know, Noma is an opportunistic infection affecting the oral and paraoral structures of the face, and it's reported to have a 90% mortality occurring majorly in children under 5 years of age. And it has associated contributing risk factors like poverty, poor nutrition, insufficient oral hygiene, and immunosuppressive conditions. And early recognition and treatment is usually paramount to reducing mortality and disability. And so for our study, the relevance of our study, we realized that early career dentists who are usually dental graduates with less than 3 years of clinical practice play an integral role in the diagnosis of oral diseases like Noma. And assessing their knowledge base gives insight into the challenges of diagnosing Noma. It's also a pointer to the requirements that would be necessary or needed in enforcing knowledge and also attitude in their in being able to detect Noma in its early stages and prevent mortality and morbidity. Generally, the aim of our study was to evaluate the knowledge base and attitude of early career dentists on the management of Noma in Kano Teaching Hospital, Kano State, Nigeria. So we went through the literature to try to find out possibly if there was any study that was done to show the level of knowledge and the attitude that professionals like dental graduates with a BDS degree would have. And we realized that there was really positive, there was positive information on the knowledge base and the attitude of dental graduates in Nigeria. And so we decided to check on the literature and found out that in Zambia, a similar study was done. It was done majorly among primary healthcare workers because they were the people that usually come in contact with Noma patients on first contact. And while most of the respondents had suboptimal knowledge about Noma, 11% of them had an above average knowledge about Noma, and 40% of them were found to have optimal knowledge of treatment of Noma. And then in another study done in Burkina Faso, we found out that 70% of the primary healthcare workers had suboptimal competencies. That is, they probably knew about Noma, but didn't have the necessary information and the skill set to be able to treat and probably refer patients with Noma. In another study that was done in Mali, we found out that among traditional healers, 10% of them, just 10.5% of them had knowledge about Noma. And so one of the key players in early detection and early detection and treatment of Noma is the health workers or the health professional being able to detect it and then pursue management. In Nigeria, due to the paucity of this data on the knowledge and competencies of health professionals, this was the reason why we decided to carry out the study. So on our methodology, we we kind of developed an electronic survey using Google Forms, and this was sent to about 60 early career dentists within Aminu Kano Teaching Hospital, and 32 of them responded. All respondents were grouped based on their dental specialties, whether they were residents within the hospital, whether they were just general practitioners within the hospital, or whether they were just house officers, those who are carrying out currently on their internship program. And questions on knowledge included inquiries about etiology, treatment, and rehabilitation of Noma cases. Questions on attitude included perception on the timing of presentation, the communication with patients' relations, the clinical diagnostic abilities, and referral modalities. From our result, above average knowledge on Noma management, 53.1% of them pointed that most of their knowledge were acquired from the classroom lectures. 33.3% of the respondents claimed that they had seen more than 6 cases of Noma in their short clinical experience. And 70% of them had clinical experience beyond 1 year, and with a mean of about 2.6 years, plus or minus 2 years in clinical practice since graduating from a basic dental degree. So from our study population, we discovered that 34.4% of our study population were general dental practitioners, and the number of cases, 3 cases of Noma. Most of them, like I said, had seen or had attained knowledge, 4.4 clinical experience about Noma. From our inferential statistics, we're able to get that statistical significance, the association, between knowledge and a previous experience of Noma case was statistically significant, meaning that with more exposure or increased exposure to a Noma case, then there was improvement in the knowledge of the dental practitioner to Noma and its management. So based on the attitude, we found out that many of them agreed that a lot of cases presented in their later stages, and many of them presented in a very critical stage. And many of them found, many of the dental practitioners or dental professionals found out that it was quite easy in their practice to diagnose a patient with Noma. And they found they agreed, like 43.8% of them strongly agreed, and others agreed that immediate referral of such patients to the maxillofacial surgeon was the best practice. And rehabilitation of patients is quite challenging. According to the data obtained, it was quite challenging for many of them to be able to rehabilitate a patient with Noma. And many of them agreed that a special kind of, not just treatment, but rehabilitation of Noma cases. On our discussion, although Noma cases are generally considered to be rare, knowledge about Noma was quite adequate among early career dentists. And unlike the previous study in Zambia, where the knowledge was found to be quite limited among primary healthcare workers. The strong association between knowledge levels and experience of a Noma case can be connected to 71.9% of the study population having a previous experience of a case of Noma. And then another reason may be that the clinical experience with live patients augmented the traditional in-class educational modalities. One of the strengths of our study is that it gives an insight to the attitude of a critical subset in clinical triaging. That is, most dentists had a knowledge about Noma, they could diagnose Noma, and it gave us an idea that, okay, many of them are not lacking in the knowledge of Noma, but probably would have to improve on their attitude towards the management of patients with Noma. So from our conclusion, we concluded that early career dentists studied had a good knowledge of Noma and its management, but would require improvement in exposure to Noma cases and to be able to obtain hands-on practical skills and improve their attitude towards the management of Noma cases. So we recommend that more studies should be considered, especially among primary healthcare workers in Nigeria on Noma management, as many of these cases usually present from rural communities, and these cases would present first to the primary healthcare centers. Thank you very much.
Hello, my name is Alice Trotter, and I work at the Centre for Applied Human Rights at the University of York in the UK. And I'm pleased to have the opportunity today to present some findings of research jointly conducted with Dr. Joanna Chisness. This has formed part of a wider project called Noma, the Neglected Tropical Disease, an interdisciplinary exploration of its realities, burden, and framing. In this research, we were interested in understanding how Noma is being communicated at the international and national levels, and how this may open up paths for informing and enhancing advocacy. So what was the focus of our research? 2 advocacy frames of Noma that are in operation today. Noma is a neglected tropical disease, and Noma is a human rights issue. In comparison to medicalized or humanitarian-based approaches, neglected tropical disease and rights-based framings of Noma are relatively recent occurrences. And our research was premised on the position that understanding how these frames function in practice may provide unique insights into ways to take action on Noma and enhance and inform advocacy efforts. But before I discuss our method and then our findings, I wanted to give a brief introduction to these frames. First, the human rights frame. So just under 10 years ago, the Human Rights Council Advisory Committee published a study on Noma. Here, Noma was found to be a cause and effect of numerous human rights violations, of the rights to food, to water and sanitation, to health, to housing, to education, and to equality. To date, this study remains the most authoritative and systematic analysis of the human rights implicated for those people at risk of and surviving Noma. Also evident in the last decade are the efforts of non-governmental organizations and academics to advance Noma's prominence in the global health regime. These endeavors have centered around the communication of Noma as a public health matter, demanding expansive research, awareness, and intervention. And one of the most significant results of this has been the multi-actor campaign calling for the World Health Organization to list Noma as a neglected tropical disease. So the first stage of our research was a narrative literature review. From the outset, we were guided by social and political theories of framing, which hold that a topic or issue can be viewed from a variety of perspectives. The means of enacting the process of framing are frames, meaning the rhetorical tools created to advance specific understandings of an issue. Framing, then, is a method of communication. It has been defined by McAdam and others as the conscious strategic efforts by groups of people to fashion shared understandings of the world that motivate collective action. The successes of this process are dependent on coherency between the content and the context of the frame. Applying this in practice requires recognition of the fact that across time, space, scale, and audience, the same frame may be received in different ways. So when we apply this knowledge to Noma, we can understand frames as devices that have influenced how the disease is understood by stakeholders and is connected to particular forms of interventions. So I'm going to discuss 3 findings of our research. These were drawn from a series of key informant interviews with stakeholders in the Noma agenda. Participants included medical, humanitarian, and human rights practitioners. And we believe that these findings highlight possible paths for advancing current advocacy. So as I mentioned previously, a human rights framing of Noma was formally articulated by the 2012 study of the United Nations Human Rights Council Advisory Committee. In doing so, the Advisory Committee engaged in a specific form of rights-based framing, which can broadly be aligned with naming and shaming practices in human rights campaigns. For example, the committee notably included that Noma was the most brutal face of poverty and malnutrition in children, thus giving rise to some of the worst violations of the rights of the child. So whilst we do not seek to dilute the veracity of this framing, in the intervening decade, a rights-based understanding of Noma seems to have made limited progress. And we wanted to understand how this frame was being perceived by different stakeholders. What we found was quite interesting. When asked to describe the relationship between Noma and human rights, most of our participants used a violations-based discourse to describe the lived realities of the disease. However, when asked to consider the effects of this at the international level, several other participants questioned how it would be received amongst states where Noma is known or thought to occur. One participant reflected on the potential effects, remarking that Noma is a shameful disease in one sense, a symptom of poverty in so many ways. It is difficult to admit that your population is suffering from Noma. And it was responses such as these that prompted us to consider more widely the form, purpose, and effect of engaging in this type of human rights frame. So these reflections led us to our second finding, which was supported by considering a question posed by 2 prolific scholars of framing theory. So Benford and Snow ask, why do some framings seem to be effective while others do not? And we see this very much in the Noma field. In comparison to the momentum gathering behind the campaign for the WHO to recognize Noma as a neglected tropical disease, the human rights frame has been relatively slow moving. And so in our research, we began to consider the need and indeed the plausibility of modifying the focus of the human rights frame. Action on Noma could, for example, be presented as an indicator of progress towards the realization of international human rights obligations. And this could be applied both prospectively and to existing interventions. So one example could be the national Noma action plans currently being established by a number of African states. And these action plans could be communicated as a step towards states realizing obligations incurred under the rights to health, food, and substantive equality. Several other participants suggested that the human rights frame could also be adjusted by connecting Noma to the global agendas and monitoring mechanisms established in the Sustainable Development Goals. So it's possible that modifying the focus in this way may promote the participation of states in the mechanisms that sit behind the human rights discourse. As one participant observed, presenting states as leaders in the fight against Noma is a good way to move forward. And so on to our final finding. Given the momentum currently gathering behind the campaign for Noma's listing as a neglected tropical disease, it seems likely that this frame will continue to circulate. It may even be prioritized over the next 2 to 3 years. Acknowledgement by the WHO would, as one participant concluded, secure more visibility, more funding, and the involvement of more actors in the Noma agenda. However, several participants held that a human rights-based framing of Noma was and should be secondary to pursuing these benefits. It's difficult to assess whether this is a position widely held in the Noma agenda. However, our findings really suggested that these frames of Noma could and should be considered compatible. It is crucial, as several contributors highlighted, to ensure that a human rights-based understanding of Noma is incorporated into planning and programming at all scales. This is particularly important for when and if Noma is recognized as a neglected tropical disease. Ensuring application of a rights-based approach may promote the participation of people affected by Noma in operation work and agenda setting. And it may also promote a shift from purely medicalized approaches towards a more holistic understanding that prevention requires tackling the social, economic, and cultural dynamics that give rise to Noma. Thank you very much for listening.
Yeah. So, hello everyone. Thank you for this opportunity to present our research work, which is titled Factors Affecting Mouth Opening Changes in WHO Stages 3 and 4 Noma Patients During Initial Hospitalization. My name is Victor, and I'm presenting from Noma Children's Hospital in Sokoto State, Nigeria. So, according to WHO, Noma is categorized into 6 stages, that is stages 0 to stage 5. The restriction of mouth opening, otherwise known as trismus, is one of the functional complications that affect Noma patients. When this complication sets in, the oral hygiene of Noma patients are compromised, and also they experience feeding difficulty, and not to talk about the psychosocial factors which they face. The restriction in mouth opening occurs during the transition of stage 3 to stage 4 of the disease. Commencement of physiotherapy at these stages could prevent severe restriction of mouth opening. Most published literatures have emphasized on post-operative physiotherapy for Noma patients in the stage 5 that had undergone surgical reconstruction and trismus release. But there has been little or no evidence that have talked about the role of physiotherapy in stages 3 and 4 of Noma disease. At Noma Hospital here, we initiate and incorporate physiotherapy management into the treatment of Noma patients during these stages. The focus of this study, the aim of this study, is to identify factors that affect changes in mouth opening in Noma patients in these stages, and also to describe the role of physiotherapy in Noma patients in stages 3 and 4. The physiotherapy technique that are involved in these patients includes the active and passive jaw mobilizations, using of wooden tongue depressors to bring about some level of stretch to the soft tissues during healing. And also, we incorporate training of the caregivers also now to carry out the simple exercises. Our study was a retrospective review of routinely collected data of patients, normal patients that were admitted into this hospital from 1st of May 2018 to 1st of May 2020. We enrolled WHO stages 3 and 4 normal patients who had not undergone any surgical reconstruction but received physiotherapy assessment and treatment. Relevant variables were extracted from this data, which include the socio-demographic characteristics, such as the age. We collected the mouth opening measurements at admission and at discharge. We had the length of hospital stay, the number of physio sessions that were completed, and also the relationship of the caregivers to the parents, to the patients, and also if patients had a sequestrum removal or not. We carried out a peer test, bivariate, and multivariate analysis. Our study also we had to seek for ERB exemption, which our study qualified for. Now, looking at the results slides here, we have the characteristics of the patients, the different variables which we analyzed in the study. Now, the first one here, we see the age. Age was not analyzed as a continuous variable in this study because it wasn't normally distributed. Hence, the categorization of this variable into two groups. We have patients between 0 to 3 years and those above 3 years. And we could see that we have almost the same proportion of patients in this variable. The reason why we also opted for this categorization is because patients that are between 0 to 3 years are not able to participate well in physio sessions due to the ability not to be, due to the fact that they could not comprehend what physiotherapy is for them at that time. But those that were above 3 years participated more because they had more understanding and they could comprehend better when they have been explained to what we're trying to achieve for them with physiotherapy. The average number of completed physio sessions in this study was 12. And in this study, we see the maximum number of physio sessions that the participants had was 20. And also we could look at the length of hospital stay, the caregiver relationship, the defect side. We had about 78% of normal patients had cheek defects. And also we had whether patient had sequestrum removal or not. And in the next slide here, we add the box plots showing, we have two box plots here that we're talking about the mouth opening of our patients at different time points. The first box plot was about the mouth opening at admission and the mouth opening at discharge. The mean mouth opening at admission from this study was 17.6 mm, while the mean mouth opening at discharge was 24.5 mm. Now we could see from this that there's been a positive change in mouth opening. There's been an impact of physiotherapy on the mouth opening changes of these patients. We had a mean difference of about 6.9 mm in this. Now, the second box plot, which shows the changes in mouth opening for the different age groups. Now, we had improvement within these two age groups, the different age groups. But we noticed that those between 0 to 3 years had a mean change in mouth opening of 4.5 mm, while those within the age group of 3 years and above had a mean change in mouth opening of 8.9 mm. And then there's about a difference of about a mean difference change in mouth opening of about 4.5 mm. So with this, we could see that older children, 3 years and above, had more improvement in mouth opening than those that are between 0 to 3 years. We carried out a bivariate analysis, and after this, we noticed that the length of hospital stay, the number of physio sessions, and the age group above 3 years were associated with improved mouth opening. But on checking for the assumptions while we were carrying out our multivariate analysis, we saw that there was a multicollinearity between the length of hospital stay and the number of physio sessions completed. So we had to drop the length of hospital stay and then carried out a multivariate analysis on the number of physio sessions and age group above 3 years. And our results showed a statistically significant value that leads to the fact that the number of physio sessions and age group above 3 years had associated, they were in mouth opening. So for an additional physio session that a patient receives, there's an increase in mouth opening of 1.2 mm. Also, being aged above 3 years also brings about more improvement in mouth opening. Conclusively, our studies show that the prompt commencement of physiotherapy in stages 3 and 4 of normal disease in normal patients brings about improved mouth opening. And also, we could see that an increased number of physio sessions and being aged above 3 years also brings about better improvement in mouth opening. We studied at some limitations, and being a retrospective study, we could only analyze the data we had, and also we had some challenges categorizing these patients into the different stages 3 and 4 of normal disease. But finally, we see that with physiotherapy, normal patients in these stages get improved mouth opening. We work on achieving a mouth opening that is 20 mm and above, because 20 mm mouth opening, anecdotally could see that it's functional for normal patients to carry out a normal oral hygiene and also for feeding. Yes, the mouth opening of normal patients cannot be the same as someone who never had normal. But working with this functional mouth opening of 20 mm, and which we see in our study that at discharge, we had an average of 24.5 mm mouth opening achieved. We could see that, yeah, physiotherapy was able to improve mouth opening of discharge, and also being aged above 3 years bring about better improvement in mouth opening. Thank you so much for this opportunity. Here are my references, and I also want to thank those patients that participated in this study, and also thank the co-authors that contributed enormously to the success of this study. Thank you everyone for your time. Thank you for listening. Thank you.
A massive thank you to our 4 presenters, Basil, Esther, Alice, and Victor. Thank you so much. It was great to see this huge scope and breadth of the different themes and approaches to Noma Research that you've kindly presented and shared with us here today. We're very lucky we have you live for a few minutes now to take any questions and comments from our audience, answer a few questions. There's been a lot of discussions prompted by these presentations in the chat already. So you've definitely given us lots of food for thought. It wouldn't quite be a live event if we didn't have a few connection problems. So I see Alice is on screen, which is great. And welcome, Alice. Hi. Where are you tuning in from?
From New York.
New York. Oh, okay. Oh, York, not New York. You surprised me there. You're working with Dr. Ioana Chisma's team, obviously human rights, Noma. This has been really an ongoing approach and framing of Noma. So delighted to have you here. Hello. Nice to see you, Basil.
My pleasure. Morning.
You're tuning in from Nigeria, I believe?
Yes, Nigeria, just Plateau State.
Brilliant. Well, thank you so much. I will give our other presenters a couple minutes to join us. Okay. I see we have, great, Victor's here. Okay. Welcome. Hi, I'm Marianne. We can hear you. The connection is a bit unstable, but we'll do our best to get your questions and answers. So perhaps while we just wait for Esther to join, we can start with perhaps the burning question that everyone would like to ask you. We've heard all day there are huge gaps in Noma research, and clearly you've been through the process and you've been published. And before we delve into perhaps more of a detailed questions about each one of your presentation, I would like to ask you what, in your own experiences, what were the challenges that you faced, particularly trying to undertake research in Noma specifically? In no particular order, perhaps just following from the order of the presentations. Basil, maybe you would like to go first?
All right, thank you very much. One of the major issues is late presentation of patients. Oftentimes, they are first managed by, we call them chemists in the villages, traditional health workers, before getting to even community health extension workers, and then going to a general practitioner. Some don't know that it's an oral health related disease condition, so possibly they'll start minor management, and before they know what's happening, it extends to the stage 3, stage 4, which is reconstructive. And sometimes chain of referral is always an issue. We have patients lost in transit. The Noma Children's Hospital of recent became known to so many oral healthcare providers that reconstructive surgeries could be done there even at no cost. So oftentimes we just manage the symptoms and send back the patients to the villages. And most of the patients, in terms of finance also, they don't have the finance to even transport themselves or their relatives to the normal hospital for proper care and all that. That's basically some of the issues we found out in Noma Research.
Brilliant, that's really interesting. I think, Esther, perhaps you may want to share some of your thoughts through the chat, then we could read those from you if you have the chance. But in the meantime, Alice, how about yourself? Coming from a very different perspective, of course.
Yes, so I think where our research really started from was this idea of whether the human rights approach or a public health approach can or should be compatible in practice and in theory. And that's really where we started from. And it was interesting as we spoke to more and more people how people have quite particular opinions that the public health aspect of Noma should be prioritized, the medical intervention, or people believe that a more holistic human rights approach should be prioritized. But really, as I hope we presented in the slides, what we found was that actually the two can be complementary, but the challenge is maybe to get to the root of those beliefs that maybe they can't be, that people think that they are at odds or one should be prioritized more than the other.
Fantastic, thank you. Oluwale, Victor, what about yourself? What were some of your main challenges in conducting your research? Looks like the connection with Victor has dropped. Oh. Okay, I think we'll come back to you in a moment. There was a question earlier on. I think it was actually possibly aimed at Yuka, and it came in a little bit after she disconnected. But someone was asking about, sorry, it was specifically looking at funding for certain types of research. So maybe we could broaden that to yourselves and say, in terms of funding, the landscape, obviously, we know that is not great, but where were you able to turn to, and where do you perhaps recommend that other researchers who'd like to come down this route of Noma research, where should they be looking? Sorry, Basil, Alice, go ahead, please.
So we have, as a project team, I think other members are here. We enjoy incredible funding from the Swiss Network of International Studies and from other non-governmental organizations. So it was, we started with the Swiss Network, and then afterwards we broadened out, and it was difficult at times, but we focused principally on one pot of money from the Swiss network, and I think there'll be other people in the chat that I'm sure that will correct me. There's other I think it's the Swiss National SNF as well, which also offers money for projects such as these that people might be interested in.
Fantastic, thank you. Basil, any suggestions?
In terms of, please, can you repeat the question again?
Yeah, absolutely. Did you find sources of funding for your research, and what were the challenges there, and also what might you recommend to other researchers who would like to engage in this sector?
Oftentimes, you don't get funding in early stages. We are trying to create an advocacy for Noma, that is a neglected disease. So it's after the advocacy sells to the public and the government, and through policies and some other NGOs comes in, then fundings will begin to come. But these are sacrifices we do as health workers to go and get the data, present it to the public, and then the funding comes. But during my research, there was no funding. It was basically personal funds. Thank you.
Thank you. Victor, I noticed you were muted. Maybe that's why we couldn't hear you, or perhaps the connection is just quite simply not good enough. But if you are able to hear us, it'd be great to hear about some of the challenges you had, whether in terms of completing the research, whether in terms of obtaining the funding. I'll give you a few moments to respond. Hopefully we'll be able to connect with you. Okay, at the moment it's not looking, it's not looking positive. However, there's been a lot of questions for you, particularly around physiotherapy, and quite detailed questions there. So if anyone would like to continue on this theme and hear some thoughts, there's been quite a lot of chat around this topic, and perhaps Victor, we could also invite you to answer some of the questions directly in the chat, since we can't seem to get you to connect. Sorry about that, everyone. So Alice and Basil, we've got questions that were sort of aimed at you now, a bit more specifically related to your work itself. A question from Samu here. So, no, sorry, a question. I'm not sure who posed it, because due to technical error, lots of people were called Elise. So, and nonetheless, a question for you. Thank you for your presentation. And can you comment on the wide age range in the study? So, perhaps, how did you organize this? How were you working around with this? And what were some of the main conclusions based looking at the age range? And that's
the question meant for me?
Yeah, that's for you, Basil.
Okay, the age range from the records, it was between 2 years to 65 years. From the case file retrieved, look at the age at presentation, and then the largest, the elderly that presented, so was 65 years old. So it's basically 2 years to 65 years. So we have to categorize them for ease of analysis, 0 to 16 as children, 17 to 59 as adults, and then above 60 as elderly. So that was how they presented.
Perfect, thank you. And a specific question for your work, Alice. So looking at Noma from the human rights perspective, a question from Ibrahim Inoariba: what role does the government have to play in it? And perhaps we can broaden that question to say also, how can we influence governments to really push this up their agenda?
It's a really great question. Thank you very much. So we feel, if we start with the human rights frame, that this is a body of knowledge that really starts with the state itself and the obligations that they derive to the individuals within their jurisdictions for the rights to food, to health, to water, to sanitation, all of the rights that are at risk of vulnerabilized when a child develops Noma. So the state really is a crucial actor. And one of the origin points for this was Joanna produced, in collaboration with others, a report by a mechanism of the United Nations, which, as everyone knows, is very much a state fora. And in that, I referenced in the slides, Noma, it was presented as a cause and effect of numerous human rights violations. And we could classify, looking back now, this framing of Noma probably as sort of a naming and shaming approach. So what we found in our research is that maybe it's time to think about this a bit differently, and maybe this might be what would bring more states into adopting a human rights-based approach to Noma if we thought about it as taking action would be an indicator of a state realizing these human rights obligations. So it's a really great question, and unfortunately we didn't get opportunity to speak with representatives of states, so we cannot sort of back up what we're thinking at the moment. But particularly with the momentum that's gathering around the NTD campaign, it seems now is the time to think again about how we talk about Noma as a human rights issue. So yeah, I hope that answered.
Absolutely, thank you so much. There would be many more questions. I'm sure we've come to the end of the time for our Q&A, but thank you so much, Alice. Thank you, Basil. Thank you also, of course, to Victor, despite the connection problems, and Esther, and I believe you will all be staying on in the meeting, so you definitely can be contacted through the chat function, and then just in a wider sense through your emails and your research groups. So thanks a lot for sharing all this work with us, and we really look forward to keeping in touch.
Thank you.
Thank you. So I do hope that this has inspired and provided lots of ideas for future research. And so kind of in that line, we're now going to move and hear a little bit more about some ongoing research. So in our next segment of this Noma Research Day, we're going to hear from 5 researchers who responded to the call for abstracts earlier this year, ranging from the etiology of Noma, the prevalence, nutrition, and the role of community knowledge advocacy. So really, again, a nice and varied spectrum of research. And so I'd like to thank very much and congratulate as well for their selected abstracts, Dr. Nsikakabasi George, Dr. Florian Gehre, Adetula Ifeoluwa, Ifeanyi, Uzochukwu, and Dr. Joel Rosenbloom, who are all now going to be sharing with us details of their ongoing research in Noma. Over to you, Dr. George.
Thank you so much, everyone, for having me on this Noma Research Day. My name is Nsikakabasi George. I am a public health professional based in Kano State, Nigeria. I work with the Zero Noma Initiative as the programs director here in Northern Nigeria. I'll be presenting on community knowledge, health-seeking behavior, and preventive practices of Noma in Kano State, Nigeria. As we all know, this is the Noma Research Day, and I believe that a lot of us, we already have knowledge about Noma, and we've also heard from other speakers on Noma. So I'll just go straight to the details about the presentation. So for me, Noma really remains a major disease that should be targeted for elimination by, because number one, it has not been listed among the World Health Organization listing of entities, which is really a problem, and also was not recognized in the London Declaration of Neglected Tropical Disease. So because of this, we have limited researches and limited funding also into this area. All right, so the problem, the World Health Organization in 1998 stated that over 140,000 cases of Noma were seen per annum. And in Nigeria, 37,646 Noma cases were recorded in Nigeria by the Nigerian Center for Disease Control between the year 2011 and 2017. We can really see that this is really a great burden, and also the prevalence also is really high. Then no data also exists on the knowledge, getting to understand people's perception also about Noma in the community, and also their knowledge too, and the preventive practices too adopted by these community members to target Noma for elimination in Kano State. The objective of this study, the general objective, is to ascertain the community knowledge, health-seeking behavior, and preventive practice of Noma in Kano State. Then the specific objective, number one, is to ascertain the knowledge level of Noma among community members, health-seeking behaviors toward Noma. The third is the preventive practices of Noma among community members. The fourth is the barriers to Noma prevention. And lastly, to ascertain the roles that traditional and community leaders play in the prevention of Noma. All right, so for the methodology, this study will utilizes a cross-sectional descriptive study, and a study setting is Kano State, Nigeria, and northern Nigeria. And for the sample size, we have 500 respondents for quantitative, because this study is a mixed study. We also have 15 respondents for qualitative, which will be the community leaders and the traditional leaders. Then the data collection instrument will utilize structured questionnaire for qualitative data and key informant interview guide for the qualitative data. So the structured questionnaire is for quantitative, and then the key informant interview is for qualitative. Then the data analysis, so for the quantitative data, it will be done using SPSS, and for the qualitative, that will be done using in vivo. Then the public health implication of this research, number one, is to expand the knowledge base, because there are limited researches when it comes to Noma as opposed to other entities. Secondly, provide the opportunity for other states in northern Nigeria and states in the Noma belt, so to target Noma for elimination, and also other African countries, most especially sub-Saharan Africa, where we have the burden of Noma, so to target Noma for elimination in their countries, and also better engage communities in so doing. Then also inform health policy making and planning at the State Ministry of Health in Kano, at the Federal Ministry of Health, and also at the Ministry of Health in every other country. And lastly, it will also impact on the public health preparedness, so how we prepare for diseases and also respond toward NTDs, neglected tropical diseases, including Noma. All right, thank you so much.
Hello everyone, my name is Florian Gehre. I'm from the Berner Nocht Institute for Tropical Medicine in Hamburg, Germany. And I'm going to tell you 5 minutes about our study that we are planning to do in Niger about the etiology of Noma. I'm quickly introducing also my co-authors on the study, which is Dr. Mona Afara. She's also from the BNITM. Professor Seydou from the University in Niamey. Professor Jambu from the Pasteur Institute in Niamey, and then we are working together with Dr. Ibrahim and Dr. Issa from Hilfsaktion Noma in Niamey, and our colleagues at Cambridge University, Dr. Sargent, Dr. Enright, and Professor Afara. You've heard probably a lot about Noma already today, so I'm keeping my introduction very brief. As we are looking for the cause of Noma, so far studies showed, or could not really show, that there's a bacterial cause for Noma. Some thought maybe it's Fusobacterium related, but it was never really conclusively shown. Neither do we think there's a genetic cause, because otherwise Noma would really run in families, which it doesn't. It's occasionally observed in twins, but so we are also excluding basically a genetic cause. So the hypothesis of our study is that this could be an epigenetic cause. And why we are saying this, we are looking at studies that were done in Gambia before, not on Noma, but where they looked basically at children that were born to mothers that were pregnant during the dry season or a time where the mothers were malnourished. So these children born to malnourished parents or mothers were prone to infectious diseases all through their life, which was later then attributed basically to an epigenetic predisposition. And this is basically what we are also thinking about the Noma children, whether they are born maybe to these malnourished mothers and have an epigenetic predisposition. What do we want to do exactly? We want to look at Noma patients and compare them with their siblings and also their mothers. And we want to compare them in terms of genetics, and then to see if there is a genetic cause and probably exclude that. And then also look at the methylation and the mRNA expression of in these patients compared to their controls. And then also, since we have the samples already, looking at the microbiome. Very briefly, in more details, what we want to do really is that we look at 20 families. This is a pilot study where we have basically 20 Noma cases. We compare them to their brothers or sisters, the next ones, and then to their mothers. We're collecting blood from them, and from this blood we extract DNA, and that DNA is then being used for genotyping them and looking for a genetic predisposition. But we are also already looking then at the methylation status of the DNA that we extract basically for the epigenetic cause. Moreover, what we want to do is also we're going to collect swabs from the cases. For the Noma patients, basically we collect swabs of the healthy cheek and then also swabs of the Noma cheek, and we extract DNA and RNA from both of them. And then also we do that for the brother or sister, where we obviously can only look at a healthy cheek, and then we extract DNA and RNA. With this DNA, RNA from the swabs, we're going to look at the methylation profiling again, looking for the epigenetic predisposition basically, and see if whatever we find, we can correlate also with the mRNA expression. And then because of having the samples ready, we will also still look at the microbiome, which is especially the 16S microbiome, basically the bacteria in the samples. So what have we achieved so far? We basically set up this study already over the last years, and we already collected samples, but the problem was initially where we thought most of the samples of the patients, they're already on antibiotics treatment. But since antibiotics are so widely spread within the communities, it's basically impossible to get children before treatment. So we will accept that now. And then the other issue that we had, that we tried to extract DNA and RNA locally, but the quality was not good enough. So now we are working together with the Pasteur Institute, with CERMES in Niamey, and we hope that this will improve the DNA and RNA extraction, and then they can be sent to Cambridge for the further analysis. And already we have the ethics approval, obviously, so we can basically start sampling. Yeah, I think this is a quick overview of what we want to do, and hopefully then in a few years I can give you some more results of the study. And I want to thank you for having this presentation. And yeah, I'm open for any questions. Thank you very much.
Yes, good day everyone, and I hope you're having a nice time in this Noma Research Day. My name is Dr. Ifeoluwa Adetula. I work at the Preventive Dentistry Department of Aminu Parenting Hospital, and as a volunteer with Zero Noma Initiative. It's an NGO that focuses on the prevention of Noma. My co-author is Dr. Nafisat Tijani, and she works at the Community Medicine Department of the same hospital. The title of our work is The Prevalence and Geographic Mapping of Noma in Kano State. I need not to bog us with what Noma is, because many people have discussed that. So I'll just go straight to the details of our work. And the background to the work is that currently in Nigeria, we do not have an official data on Noma. However, there's some work ongoing. Also in Kano State, with the population, with the frequency of seeing these cases at intervals, we do not know the actual burden or like an estimate of it. So those are the reasons why we're embarking on this work. And the research question we are trying to answer is, what is the prevalence of Noma in Kano? And in addition to that, what can we have an idea of how, the distribution, the spread, which part of the state do you have it more to guide intervention? So we plan to go about this study first by looking at the clinic list of the maxillofacial unit of Aminu Kano Teaching Hospital. Aminu Kano Teaching Hospital is a referral center, it's a tertiary hospital, and cases are referred there from almost all the parts of the northern part of Nigeria. So we look at the clinic list dating back to 10 years to give an idea of, we want to gather details of cases of Noma that were seen from Kano. Now, having gotten that, we also take into consideration the political arrangement of Kano State. Kano State has 44 local governments, and the way the state is structured is that it's divided into 3 central districts. Two of these districts have 15 local governments each. The third one has 14 local governments. So we are going to use the clinic list, along with this arrangement, this political arrangement, to get a sense of the hotspots where these cases are. And in doing that, we systematically pick 3 local governments from each of the districts. That makes it 9. And having chosen the 9 local governments, we conduct a field survey. In the field survey, we're going to get a print material that depict what Noma is, the stages, and some information in the local language we are going to give to the people. Such a language that they understand, and it will help us to fill the detail. And the data we collect, we enter it into SPSS IBM version 25 for analysis and to make inference. And of course, because we are dealing with data, human record, we are going to get consent, get ethical approval from the hospital, and also consent from the people who are going to help us who are going to be involved in the survey. And having entered the details and analyzed, we expect to have a rough estimate of the cases of Noma in Kano, and also in addition to also have an idea of the spread, so that we can adequate intervention can be planned towards Noma, and together we can achieve zero Noma. I thank you very much for your time. Have a great day.
Hello, my name is Ifeanyi Uzochukwu. This project is studying the host microbiome interaction, one, and then the microbiological etiology and nutritional risk factors involved in a Noma disease. It is a case study of the Noma Sokoto Hospital in Nigeria. The collaborators, my principal supervisors for this project is Gordon Proctor, and then Mark Ide, who are faculty heads at King's College London. Firstly, the specific microbiological etiology as well as the nutritional risk factors has not well been studied for Noma. I would like to commend the excellent work done already on public health in ascertaining the public health, giving public health knowledge of Noma in Africa. Moreover, this project seems to build upon that. We want to understand primarily the interaction that goes on between the host cells and the microbiome community, which leads to the Noma disease. Secondly, we want to understand the based on the previous public health research, which ascertained that for a lot of the cases for Noma at the Sokoto Hospital, many of the children were fed with pap daily, as well as they had a single water source. So based on these findings by Elisifale in 2020, we want to conduct a study to know whether that these food and water sources are a possible causative source of the microbial community, which leads to the infection. Now, the aim of this research is in three ways. Firstly, to identify potential causative factors in the oral microbiome, as I said earlier on. Secondly, to identify nutritional risk factors. And thirdly, to assess the presence of immunodeficiency in subjects with Noma as compared to the control subject. We're going to deal with 100 samples, where 25 of them would be confirmed cases of Noma, 25 confirmed cases of accused necrotizing Noma, 25 confirmed cases of malnourished children, and finally 25 cases of siblings of the Noma cases, which would be our control. For the methodology is going to be in three phases, and the summary of methodology is that after the sample collection from the participants, we're going to have sample collection, and as well as the food and the water sources being collected, we're going to do a dark field microscopy as well as immunofluorescence assay to ascertain and as well as some basic microbiology to isolate the possible organisms which are causative of this Noma. And then secondly, we're going to the saliva and the serological analysis for antibiotics against EBV, CMV, and HIV serum levels or biomarkers of chronic inflammation to understand the immunocompromisation level of the virus to Noma itself. Thirdly, then there will be a measurement of serum immunoglobulin levels and T cell count, then extraction of DNA from the isolate for 16S RNA gene sequencing. And then the last stage of the research will involve metagenomic microbiome sequencing and analysis, which includes resistome study and salivary biomarkers of periodontitis, gingivitis, and other related oral health diseases to understand how susceptibility to other pulmonary diseases such as periodontitis, gingivitis, makes the children more susceptible to Noma itself. I would like to say a big thank you for being selected for this project.
Bonjour tout le monde. My name is Joel Rosenbloom, and I'm a dentist in Canada. I'm an assistant professor teaching stream at the University of Toronto Faculty of Dentistry. I'm also a staff dentist at the Centre for Addiction and Mental Health, CAMH in Toronto. I'm also an adjunct professor at Addis Ababa University. Today I want to talk about a project that we're working on at the dental school here called 1 Hour for Noma. Going back to my experience with Noma, I first saw a child with Noma in 1987 when I was working in Mozambique as a dentist. Like most people who first encounter Noma, I found it a very deeply moving and affecting experience. It never left me. I didn't talk about it or write about it much till many years later. In the last few years, our dental school has become heavily involved in global health. About a year and a half ago, I wrote an article about Noma to publish in the local dental journal to try and raise awareness. I encountered Claire Janté, the co-filmmaker of Restoring Dignity. She loaned images to the article, which then led to a collaboration where we showed the film Restoring Dignity at the dental school in January of this year. Myself and a small group of students arranged this, and we had 252 registrants. It was a huge, huge success. It was popular, it led to discussions at the dental school, and we thought as a group, we need to do more. We formed this group called NAG, the Noma Action Group. Our goals were threefold: to raise awareness about Noma, to advocate towards eradication of Noma, and to educate ourselves so that we could be better advocators and we could be better awareness raisers. So in the vein of that, our first goal, advocacy, we decided we would work with the international efforts to work towards eradication of Noma. We also wanted to advocate to our chief dental officer so that Canada could be a player on the world stage to support the efforts at the WHO to get Noma listed as an NTD. We also wanted to advocate within our own local dental community to raise awareness among dentists. And the second objective, awareness raising, we wanted to raise awareness both in the dental community and amongst the students. We decided to do this by one, showing the film, by having talks about Noma, and to write articles. We've written a number of articles in journals and short and long pieces to get people interested and more motivated to do something about Noma. The third objective was education. We wanted to educate ourselves so that we could be better prepared to do the first two objectives. Our big project that came out of NAG, which we're just starting to work on now, is called 1 Hour for Noma. It's a project where we want to prepare dental students to graduate with 1 hour comprehensive lecture about Noma. We had the first one this week in Toronto. I gave a lecture to the dental students at the University of Toronto. There's 10 dental schools in Canada. We're working with all 9 through their federation to be able to have every single dental student in Canada graduate with a good, deep, solid understanding about Noma. Only then will they all become more motivated and able to advocate and work on the world stage to build coalitions and awareness to slowly get rid of this horrible disease. I call to other universities, to other educators to consider this project. It's easily adaptable and the outcomes can be huge. Thank you very much for listening. Have a good day.
Well, indeed, a very, very big thank you to our presenters in this section, Dr. George, Dr. Gehre, Dr. Ifeoluwa, Ifeanyi, Uzochukwu, and Dr. Rosenbloom. Thank you so much. I hope that we're now able to bring you on to the center screen following your interventions. Great to see you, Joel. Hi.
Hello.
Hi. Hi, Ifeoluwa. How are you?
Very fine, I'm good.
Florian,
how are you doing?
We're all good, thank you. It's great being here. I can see Florian.
Yes, hello.
Hi.
Thank you very much.
I will just give a few more minutes, just making sure. I believe Dr. George won't be able to join. Okay, well, let's not get bogged down by connection problems interfering with one of the most exciting meetings of the year. And thank you so much for sharing your work and, more importantly, really your perspective on Noma Research. And there's just really one question we wanted to ask you all, because what was really striking was kind of the diversity of backgrounds. You're at very different stages of your careers. You also come in from really different disciplines or optics. And so I just wanted to ask all of you who kindly shared your research today, what is it that brought you to doing research specifically in the field of Noma, and also what would you like to achieve with the particular piece that you presented today? Perhaps we'll start with you, Florian.
Yes, okay. Hello, everyone. I still need to mention quickly, I think I didn't mention it in my presentation, that the study is also funded by Hilfsaktion, so I'm very grateful about that. In general, what my whole background is, I'm a molecular microbiologist, so I worked for a long time in Africa. I worked in Gambia for several years on tuberculosis. Now I'm in Tanzania, where I'm working in East Africa on mobile labs. So my general background is always infectious disease in Africa, Noma in particular. I mean, I guess I'm sharing that with most of people working in Noma is obviously the poor children in the end. And it would be really good if you would find some kind of cause that then could be where you could target an intervention to. So I think this is the main driver for that. And what I also actually like about the field of Noma research is that it's not very competitive and we're all pulling in the same direction. And I think this is also seen today in this meeting.
That is a really important point. Thank you. Well said. What about you, Ifeoluwa?
Oh yeah, thank you very much. Where I work, I often see cases, and I have interest in seeing that mortality is reduced. But I believe Noma exists because oral health is largely missing from the scheme of things.
I'm really sorry, Ifeoluwa, your connection was quite bad, but I think what I heard was your motivation was down to the fact that oral health is really missing from the public health agenda. I'm really sorry. I'm just going to move on to Joel. Hopefully by then your connection will have it stabilized. How about you, Joel?
Hello, hello, hello.
As I said in my presentation, Marianne, I lived in Mozambique for almost 3 years, and I worked as a dentist, and it was during the Civil War. And I saw lots of really horrific things. If anybody knows the Mozambican Civil War, it was awful. Terrible things were done to many people. Amidst all that horror, the one that stood out most for me was seeing that first child with Noma. It's something that you process in a deep sort of way, and it always stuck with me. And as I came back to global health at the dental school about 7 or 8 years ago, Noma started to come back. I was giving lectures at the school, and it got me thinking about why it stuck with me and what I could do. And I love the word serendipity, because when I tried to publish this article about 1.5 years ago, they said, we can't publish it without images. I went online and I connected to Claire, whose film was literally being released the next month. And this article was coming out, and it was this kind of unexpected connection. And she provided images, the article went forward. And since then, I've just found this incredibly open and enthusiastic audience in Canada amongst dentists and physicians. The awareness level hovers around less than 5% in Canada. I asked my physician colleagues, many of whom are senior physicians and dentists as well, and very few of them know about Noma. So I think it was Florian who might have said that there's a lot of work to be done. And here in our corner of the world in Canada, I think awareness is extremely low. And so it opens the field for someone like myself, the students, the school, to really move forward very quickly. And as I say, in the last year, the incredible level of awareness that we've been able to raise just through the efforts that we've done has given me some hope and inspiration that we can play a role, maybe a tiny role, but we can play a role from Canada to support the NTD movement for Noma. We can play a role in just participating as collaborators with all the wonderful organizations in Europe, but there's a lot to be done, and I think there's not a lot of competition over here, so that's what keeps me going. Thank you.
Wonderful, thank you so much. And you've mentioned the film Restoring Dignity a few times, and absolutely, we are in a world where sometimes an image can do so much more, have so much more impact than researchers working for decades. And so definitely it's been amazing to see Noma being the film being screened, but also being recognized as a story that needs to be told. So that's been wonderful. And so I just wanted to thank all of the researchers today who've shared this with us. While we were talking, there's been in the chat, I hope everyone has seen that, just to go back to the question that we're discussing today, which is resources for Noma. So there are a few links that have been very kindly posted by Yuko Makino and also Matthias from Hilfsaktion Noma on funding for Noma research. Elise as well from MSF has posted a resource. So please do go to the chat and look for that. And so now we are kind of coming to the third part of our day, where we will be discussing Noma as part of a roundtable. So I just want to thank again our presenters. Thank you to all of the participants who weren't presenting but have shared absolutely invaluable thoughts and comments, insights, as well as resources in the chat. So if anyone hasn't been there yet, please do go ahead. Any questions that haven't been answered, I just want to remind everyone that the email addresses of all our researchers has been posted in the program, the PDF document that is available. So please do continue those all important conversations, because that's one of the main aims of today, is to really cement this network and cement those collaborations worldwide. So I'd like at this point to hand over to someone who actually was not able, so sadly, to participate live. I don't think Dr. Denise Baratti-Mayer really needs an introduction, but nonetheless, I will just remind everyone who perhaps is new to the Noma field. Denise has been working for many, many years to really chart and share and advocate for Noma research and those communities affected by Noma. Denise is based at the University of Geneva and is also one of the principal member on the Noma project. So I will hand over to Denise, who is going to introduce the round table, and then we will actually proceed to the round table, which is being very kindly moderated by Dr. Stuart Ainsworth. Dr. Ainsworth is at the Liverpool School of Tropical Medicine, working in the Tropical Disease Biology Department, and also affiliated with the Center for Snakebite Research and Intervention, snakebite being another one of those neglected conditions really affecting some of the poorest populations on Earth. So I'll hand over without any further delay to Denise, and I look forward to hearing all of your thoughts and all your contributions during the roundtable. Thank you very much.
Bonjour, I am Denise Baratti-Mayer. I was the coordinator of the Just Noma group, the Geneva study group on Noma, and I am now a principal member of the Noma project of the Geneva University. And I've been working around Noma for a long time as a researcher, but also in the field with people affected by Noma. Today I'm sad and happy at the same time. I'm sad because I could just pre-record something for you today, and I'm happy because this is the first research day on Noma. You have just listened to extremely interesting presentations, and you perhaps noticed that most of them are from Nigeria. This could be misleading, as one could think that Nigeria is the only country affected with Noma. But this can be explained. The first reason is that Nigeria is one of the countries with the highest number of scientific publications from Africa. The second reason is directly linked to Noma and to research. And it is because the first researcher on Noma of our times was Professor Cyril Erommonsele from Maryland, who was linked to the Sokoto Hospital and to the Nigerian. But Nigeria is a global problem, as you will hear in the next roundtable. This roundtable will try to answer two questions. What is needed now for research on Noma? And what are the key themes for future research? One of these key themes should be to show that Noma is a global problem and that people affected with Noma is living all around the world where poverty is present. I thank you, and I leave you with the roundtable.
Good afternoon, everybody. If it's afternoon time where you are, if not, good morning. Thank you very much, Denise, for a message there on why research is very much focused on Nigeria. So in this roundtable, we've got about an hour to have a real good live backwards and forwards discussion, hopefully very, very productive on Noma, and focusing mainly on research questions, where we need to go and how we can move forward as a community. I would like to touch on one of the things Marianne finished up with, and that is my day job is to work in snakebite envenoming essentially, and I came across Noma whilst working on snakebite and was introduced to it by some snakebite clinicians, and it really struck me that there are a lot of parallels between snakebite envenoming and Noma as a disease. It affects the poorest people in society, it's incredibly neglected traditionally funding wise, and it affects people absolutely globally, and the stigma and the morbidity that's inflicted by it is acute essentially. The main difference between snakebite envenoming and Noma is that snakebite envenoming, as many hopefully you will know, snakebite got onto the NCD list in 2017. And with that, there has been an absolute floodgate of funding and advocacy since then, and work to actually try and reduce the burden is well underway. Now, we want to get Noma to that position essentially. And the way snakebite was achieved getting onto the NTD list was through essential advocacy and collaboration between people in different sectors. So this discussion and the take-home message from this conference today is that collaboration is absolutely key for achieving everybody's ultimate aim, which is to help people afflicted by Noma and hopefully eradicate this disease eventually. So today in this live discussion, we've got a few things to make it a bit more interesting. We're going to have a couple of polls that are going to pop up during the discussions. Can you please just take 2 seconds to answer them? There's only 2 questions with several multiple choice answers. And then we're going to use the results of that poll to inform some of our discussion. We've got 2 key themes. One is going to be what is the most important area for future research on Noma, followed up by what is the most important, what is needed for researchers to continue their work or launch new studies on Noma. So we're going to have an introduction with 7 researchers, and then in about 30 minutes time, we're going to have a live table backwards and forwards discussion. So please do write your questions in the chat box and use the Q&A feature. And yeah, just remember the take-home message from this is to just reach out to people you've seen today that you may have not spoken to before, make that initial contact, talk to people, try and develop these collaborations, because multi-center, multi-country, multidisciplinary collaborations are much more attractive to funders globally. So without further ado, I will stop rambling massively, and I am going to introduce Anneliese Galli. So Anneliese is a PhD candidate at the Swiss Tropical and Public Health Institute, working on WASH, in areas of humanitarian crisis with a special emphasis on hand washing, obviously. And currently, Anneliese is performing a systematic literature review on the prevalence and global distribution of Noma. So, Anneliese, you want to introduce yourself and say hello?
Yeah, hello everyone. Thank you very much for organizing this research day. Yes, I have been working during the past year on a systematic literature review on the global distribution of Noma and the prevalence and incidence and mortality of Noma. And it will soon be published, hopefully. Yeah.
Excellent. Next, I'm going to introduce Mark Sherlock. Mark, are you here?
I am indeed. Thanks.
So I'd like to just introduce Dr. Sherlock. So, there comes the poll. So if you could please just take 2 seconds to answer that. So Mark is a health advisor for MSF and a program manager for MS activities in Nigeria, Jordan, and Iraq. He also works part-time as a doctor in the NHS in the UK, or has done. Mark's worked in a variety of humanitarian contexts, and obviously he's got a lot of experience with the Noma Children's Hospital in Sokoto. So Mark, you want to say hello quickly?
Yeah, hi guys. Great to be here, and thanks for everybody for joining this afternoon or this morning. Nice to get so many people around one table, and nice to hear of collaboration and people talking from very different contexts and places around the world, talking in the chat box. Nomi and Lise, our MSF Noma Research, would be here today, but there is some connectivity issues, so I am standing in. As you know, MSF has been involved in lots of different research around Noma in Sokoto for the last number of years, but we recognize that that is not enough, and we see that there's a few gaps in areas of research where we'd like to talk about and see what we can do into the future. And it's around, for me, the few of them is around burden and distribution of the disease. The etiology, we don't know enough about the etiology. We know about all these risk factors, but we don't have any real concrete information on etiology, and piecing all that together is of vital importance. And also, I'm interested in the standardization of reporting. I think a lot of Noma cases are lost within data collection in places around the world because nobody knows what the disease is. And we need to come up with standardization of reporting. And one of the big things I like to hear what Denise said just about shifting the research away from it's very West Africa focused currently, and we need to get a more global representation of Noma research. And I think that's really, really, really important. And it's great to see so many people come together today from such diverse backgrounds. And the last thing I would like to bring back into this as well is about reinstating MSF's call to get Noma onto the WHO NTD list. And I think that's an important point going forward as we look to hopefully a positive application in 2023. Great to be here. I'm looking forward to some chatting back and forward in this roundtable. Thanks.
Thank you, Mark. So I'm just going to drive through with the rest of the introductions, and then we'll get on to some of the discussion. So next up, we have Professor Philippe Gehre, who's a professor of epidemiology and global health and the director of the Infectious Disease Data Observatory based at the University of Oxford. Philippe has an extensive, I suppose it's very expensive as well, doing research, experience working in the field for MSF and a researcher for the Wellcome Trust Unit in many countries in Africa and Asia. Philippe, would you like to just say hello very briefly, or?
Yeah, thanks, Stuart, and thanks everyone for inviting me. So essentially, and I'll come back to that maybe later during the conversation and the discussion, I coordinated a team which worked with WHO on doing this systematic review of mostly treatments and prevention interventions for Noma, and the work was presented rapidly by Dr. Yuko Makino earlier today. But essentially, if I could summarize in 2 sentences, what we found is that we are at IDO working a lot on neglected tropical diseases. And it's clear that Noma is not only a neglected disease, it's a neglected disease among the neglected diseases. I mean, the volume of data and evidence which exists on Noma to date is really extremely low. And the interventions and the preventive measures that could be put in place are probably not based on very solid evidence. So that's really the key message. Now, this review is also helping WHO to put forward the case for putting Noma in the list of NTDs, and I believe that everybody is convinced that this step is not only a political step, but it's also an acknowledgement of how much more effort needs to be done in Noma. I would be happy later on to briefly summarize what we found in addition to what Dr. Yuko presented, because I think it gives a sense of how much we don't know about Noma and how much more needs to be done and coordinated. And I'd like to echo what Mark just said in relation to the lack of standardizations in capturing information about Noma, which is preventing to get any global picture of the problem. Over to you.
Thank you very much, Philippe. Next, we have Professor Kalu Ogbureke, who is a professor of oral and maxillofacial head and neck pathology based at the University of Texas. He's previously been involved in Noma Research in collaboration with research of the Forsyth Institute at Boston and the Sokoto Noma Hospital in Nigeria. So, Professor Kalu, would you like to briefly introduce yourself?
Yeah, thank you very much, Stuart, and thank you all who organized this. When I got the email, it felt like a resuscitation, and it was a very big relief. It couldn't be more timely. So you have actually responded to a very, very timely instinct by putting together this conference. As Stuart had just indicated, I was involved with the normal research or the normal question starting in the 80s, actually, as a resident in oral and maxillofacial surgery. I was privileged to be with Professor, now late Professor Emmanuel Adekeye in Kaduna at the maxillofacial unit in Kaduna. And of course, there we saw tons of cases of Noma. But of course, the focus at that hospital, and probably still is on treatment, surgical management of these patients. Moving forward, subsequently, as a postdoctoral fellow at Harvard and the Forsyth Institute in Boston, I was again involved with another group, and this time also with the Sokoto Noma Hospital, with the help of Professor Cyril Enwom, who's already been mentioned in passing here, but who we all recognize if you follow normal literature and research, would admit that he has contributed so immensely to the normal question. And in fact, his research has helped solve many of these, answers many of these questions. So it's, I would wait until we begin the roundtable. But again, it's a very, very big relief that we are having to talk about this problem now. And I'm just hoping that at the end of it, we'll be able to have actionable, clear directions on what we need to do in a very, very pragmatic sense. Thank you.
Thank you very much. And it is just like to underscore this actionable, clear objectives and directives is really, really key. So if people can brainstorm or just dive it down on paper and put it into the Q&As, what they think at the end, we can basically, it could be possible that we could collate these and send them back out to the community. We basically is setting up here and for further discussion. This just doesn't have to end today, essentially. This can continue. So next we have Dr. Michele Murdoch, who is a UK-based consultant dermatologist with research background in onchocerciasis, and she's currently the co-editor of the Community Skin Health, which is a teaching journal for frontline health workers in low resource settings. She's the chair of the NTD NGO Network Skin NTD Cross-Cutting Group, which aims to support WHO's new roadmap policy of integration of control and management of skin-related NTDs. So, Michele, would you like to just briefly introduce yourself?
Thank you very much, Stuart, and thank you so much for inviting me. I feel very much a guest in this group of people, and I have to say that I have never personally yet managed a patient with Noma disease, so forgive me for any blunders I make. I would like to thank all the speakers today for their interesting presentations as well. I have jotted down a few thoughts, and if I may, I'll just outline them now so that perhaps we could expand them later. I put forward to you, coming to this as an outsider, as it were, that this disease seems to be very much a disease of two halves. We've got the issue of prevention and treatment of early stages. And then, of course, we've got the later stages needing their reconstructive surgery. And it may be that when we're addressing research priorities, we have to bear that in mind and not try to address everything together. We may have to narrow things down to these two very big halves. The second thing I'd like to say, I'd like to highlight two areas that I see as a clinician for research. I understand that most of the studies to date, the actual stage of the disease has been poorly documented. So I think that's a number one call. My challenge to the clinicians here, the dentists that have got experience, first-hand experience of this disease, is to actually just, as a group of clinicians, just have a subgroup, get together and just make sure that you don't want to revise your classification, make sure there's no sort of subdivisions of it that you want to make. And really, the document that's the WHO information brochure, I think is excellent, that was produced a few years ago. It's got excellent pictures and it's excellent for promotion of disease awareness. But I would just challenge you to perhaps, based on that, make a new document, which might be a Noma clinical hand manual that you can just highlight the different stages and sort of subsections of it if necessary, with the relevant clinical photos and written definitions as to actually what you mean for those different stages. And bearing in mind that we don't want too many substages, this has got to be simple and it's got to be eventually used by non-medically trained staff. And then once you've really are happy that maybe it doesn't need any more work, but once you really are happy that you've refined that as much as you can from your experience together, you need to have some sort of inter and intra-observer variation study to make sure that you're all calling things the same thing. And then what you'll have is a tool to go on to the next research priority that I see, which is, of course, trying to document the global burden. Once you've got that tool, then you can start having meaningful prevalence studies. So not only do you want prevalence studies, but extrapolating from that, you'll be able to get some Galli estimates to give you the overall global burden of the disease. So what I would like to say is that I say again that I'm an outsider to this research group. I had some experience with onchocerciasis and onchocerciasis skin disease, and there are many things that had similarities with Noma. People said that where the road ends, onchocerciasis begins. And in other words, it was a hidden disease. And I think we've heard today that Noma is very much a hidden disease. So if I could just sort of extrapolate the principles of how we went about trying to get some ideas of the global burden of disease, you're going to need, I suggest, some sort of multi-country study, prevalence study, if you can. And I would propose that the studies involved are from different WHO regions so that you can get an overall estimate. So moving on, in terms of advocacy, I think we've got two clear prongs of approach here in terms of getting greater awareness and advocacy for Noma. You've heard about the global strategy for oral health that was produced earlier this year by WHO. I don't think you should feel despondent, because this is a fantastic development. You've got clearly stated aims by WHO that they want to translate this strategy for oral health into a framework, and they want to actually be able to monitor that framework with tracking progress and tracking development, so that you've got measurable targets by 2030. And on page 1 of that draft document on global oral health, Noma's mentioned, you know, you're halfway there. And then, but I appreciate that that's going to probably take quite a long time for all the enormous global change and shift in thinking into making oral health more of a reality for all the member states. So whilst that's going on, and I think you need to remain active in knocking on WHO's door there, whilst that's going on, I think this integration with the NTDs is a very prompt or a more immediate action that we could take. As you said, as people have said earlier today, Noma's not on the list of WHO's NTDs at the moment. And there are other skin diseases that aren't on the list. For example, podoconiosis is applied to be added and it didn't happen. Superficial fungal infections are not on there. But that doesn't mean to say we don't think about them and we don't sort of work with them where we can. The recent strategic framework for the integrated control of skin-related NTDs, it doesn't have a lot on Noma, but it does say that there should be a strategy for integration of a Noma with other skin NTD activities in co-endemic areas. So I think you've already got a link in, and I think that may give more immediate results. And just sort of, I've just sort of thought about where is the overlap, and there's lots of overlap with skin NTDs. If you think about the late stages, surgical reconstruction, well, surgical interventions needed for a lot of skin NTDs, lymphatic filariasis for treatment of hydrocele, leprosy, borreliosa, mycetoma, these all require surgical interventions. And I'm not saying that those surgical resources or facilities are even up and running yet. So in some ways, these theatre infrastructures have some overlap. The supply issues, the skills, the anesthesia involved, there is an overlap there. There's an overlap with wound management. So we have wounds in borreliosa, in leprosy, yaws, cutaneous leishmaniasis. So lots of things there, overlap with stigma, of course, and overlap with mental health. So I think we have got a lot in common. And hopefully, as I said, I think working with our skin NTD group is an opening, and it may have a more immediate possibility for interaction, whilst the overall strategy for universal oral health by WHO beds down.
Thank you, Michele. Some really interesting thoughts there. Just in the interest of time, I'm going to introduce the other panelists and then we can crack on. So next, the next person I want to introduce needs no introduction really, is Fidel Straub, who is a Noma survivor and amazing Noma advocate. Fidel, do you want to just introduce yourself very briefly and give one or two thoughts on today?
Hello, everyone. Thank you for having me here, and thank you for joining us here in this important meeting. I think, yes, I am a Noma survivor, and I barely made it out. And now, yeah, nearly 30 years later, I'm here in front of you and ready to talk about Noma. And I find it quite important also to include survivors like myself and others who are not here today, but I hope that this will be something which we can do more often. Also listen to survivor story, and in relation to that, I think it is also important to know the story of the survivors, what they experienced, so we can also better understand how painful Noma really is. And I think the main goal which we have to focus is really the detection and the prevention of Noma, and of course also education and inform medical staff what is Noma, how does it look like, and what we can do. If the medical staff doesn't know what to do, then there is no high survival rate. So we have a long road ahead of us. So I think if we mix also stories of survivors and explain them what we experience, what we think would be helpful. Also with the after treatment, I had quite a lot of operations, speech help with logopedic, and so I think if we can manage somehow to have a fun orchestral play with prevention, treatment, detection, and education in the health branch, I think we may be able to fight quite efficient against Noma.
Right, thank you very much, Fidel. And last but very not least is Dr. Leila Shro from Laos. Leila is a pediatrician and has done immense work in sort of raising the profile of Noma patients that are not in sub-Saharan Africa. So Leila, would you like to just introduce yourself very, very briefly and maybe 1 or 2 points reflecting on today? You're muted. At the moment.
Okay, thank you very much. Thank you, Fidel. That's wonderful. Thank you for sharing your life with us. And I just was asked to talk briefly about Noma outside the Noma belt, where risk factors exist, but knowledge about Noma is so limited. Most healthcare professionals outside of the Noma belt have no knowledge of Noma. And so, for example, in Laos, since 2002, I personally just opportunistically have met and documented 50 Lao Noma survivors from 14 out of 17 Lao provinces, and many suffered for decades throughout their childhood, adolescence, and young adulthood from the functional and cosmetic sequelae of this disease. And so what I think is that the integration of Noma education with basic public health programs in countries with Noma risk factors is the first step to eradication of this preventable childhood disease. Not only in Laos, but there are reports of Noma from India, Vietnam, China, and other countries. And then there are countries where there are risk factors where there are no reports, particularly Myanmar. A couple of years ago, I met a doctor working in China who reported an 18-year-old female with significant Noma sequelae who had crossed the border from Myanmar seeking help. So there are many areas where there are many parts of the world where people have no information about Noma. So they're not recognizing it, it's not being reported. And that's the main message that I would like to contribute, and I would like to advocate, as many people have done, for the education of healthcare workers at all levels. Thank you very much.
Thank you very, very much. Okay, so we only have about 20-25 minutes left for some discussions. So what I'd like to do is the results of the first question have just popped up on your screen, and I'd like the panelists just to discuss this for maybe 10 minutes. So the poll has asked the participants what is the most important area for future research on Noma. And I think we can all see the overwhelming winner there is prevention, with the other areas, the other suggestions, epidemiology, treatment and detection, all getting similar results. So the panelists, very broadly, would you agree with prevention as this being the most important area for future research, or is it easy just to say we must work on prevention? We can't. I mean, is it easy to work on prevention if you don't have the information on the epidemiology to back it up? So, if anybody would like to start, just jump in.
Thank you very much. I really am itching to start on this subject. What I noted was missing in the list was basic science research. This has been alluded to in one way or the other. Over the years, the emphasis has been on prevention and, of course, epidemiology, as you mentioned. And that's because of and rightly so, the perception that this is largely a public health issue. But what we have seemed to neglect over time is, and hopefully we will begin to pay attention to, is the fact that there may well also be fundamental basic science implications of this disease that have not been looked into at all. The researches have been epidemiologic, prevention, nutrition, and all these predisposing factors that are often, repeatedly bandied around, neglecting, in fact, the fact that these, as important as they may well be, that there is the likelihood, I was going to say possibility, but I think it is dawning on some of us in the basic science, carry out basic science research, and given modern technology and what we know generally now, that someone has already mentioned genetics, but beyond that, other molecular aspects that must now begin to be looked into as integral parts of the wider scope of research and inquiry into Noma. So I wish basic sciences were included in that list, not because I thought it would have won, but it would have drawn attention to these very, very important missing elements. I agree with prevention, but I do not think that it ultimately answers the question. We've been addressing the issue of prevention and epidemiologic studies and so on over decades, but we have made little progress in taming this disease, as it were.
Thank you very much. Anai, can I just ask you, with your work that you've been doing with your literature review on Noma recently, do you have any reflections on the results of that on that poll with regards to prevention being considered the most important area of research?
Yeah, I might be a bit biased because I'm an epidemiologist. So, of course, epidemiology is for me very important. We also saw that a bit in the systematic literature review. I think Philippe will have a similar result, but we did not find many epidemiological studies, or at least no randomized population-based epidemiological studies on Noma. There was one from Elise Farley, which is very recent, and I think there are some ongoing studies. But objective data on Noma is basically missing at the moment, so I think it should have a high priority. Of course, prevention is very important, and I think it's also difficult to only choose one of these aspects to go for. I think it needs a combination. And for me, also detection of Noma patients is something very important, because I think due to the huge stigmatization, many patients never get detected. Even if we would have a representative study, maybe we would not find the Noma patients. So we would have to work on detection as well. And I think that an approach could be to integrate Noma also into other programs of NTDs, but also, for example, vaccination campaigns or malnutrition surveys where oral screenings would be administered to really detect Noma patients early on.
So I'd just like to pick up on that. So perhaps Fidel and Leila can comment on this. And it was the idea of stigmatization and finding the cases for prevention. Could you comment on the stigma and how that might prevent research on Noma really taking hold? And do you have any ways that we could perhaps sort of suggest to work towards reducing the stigma?
Well, I think the thing about stigmatization is also the African culture or other culture, Asian culture, they all have their point of view to life. So most of them are quite religious. They believe in God or natural gods, and if a child is sick, it is like a punishment because they did something in past life or present life. And so I think this would be some kind of barrier to also find the patient because I think the parents are just scared that they will be expelled from the community because it is punishment, and if they are punished, it's like they are not entitled to be treated, and if they do so, they think they have to pay. And so if they knew this is a disease and it can occur and the treatment is free of charge, I think this would quite help a lot of patients. And most of the parents, they want to be fair, so that means they know if you want to get something, you have to pay normally. And I think also if they don't know that this is really free and that we help them to help cure their child, I think this would be very helpful. Yeah.
Leila, do you want to contribute anything there?
Yes, I think the stigma is at all levels, from the Ministry of Health right through to the health workers, the families, the patients. And so it needs to be overcome at all levels. In Laos, where there's both a Buddhist and animist culture, so the acceptance of people who are stigmatized in the community, they may be accepted, but they're also going to be very hidden. And so it's only going to be with full integration of Noma with other programs of public health that I can see the stigma beginning to be overcome. But I think it is a huge problem to address.
Okay, thank you very much. Okay, so now on your screens you will see the results of the second question that we've asked you to pop up, hopefully. So the question was, what do you need in order to continue your research on Noma or to launch new studies? And the four areas we listed were financial support, human resources, time, and more awareness. You can see the results are a bit more sort of evenly spread, but again, financial support is the biggest outcome here. Can I ask Philippe and Mark, what are your thoughts on this question? Because I know panelists are not allowed to answer these questions. So Philippe, if you were asked this question, what would have been your answer?
Oh, I guess I would say that if you look at the volume of research which is happening right now, or activities happening in Noma, it's so limited that clearly there is a problem of awareness and financial support. And one goes with the other one, because you can't dissociate that. I'd like to come back also, and maybe because, okay, if you raise awareness and then you manage to get funding for that, I'd like to come back to the previous questions about where do you spend your funding. And I'm going to be a bit provocative, but there is no point in saying, well, it's going to be prevention or treatment or diagnosis, or you need to do everything in epidemiology. You need to do everything. You can't separate that. Of course, prevention will prevent future cases. But if you are a child turning up in a clinic right now with Noma, you want to be treated. You don't want to say, well, no, sorry, the money has been spent in prevention. So let's be clear that here we need to approach that in an holistic way and a comprehensive way, and not trying to cut the pieces into pies, which doesn't quite make sense. And there are so many, because without the understanding, and maybe also that sort of a fit to the point that Dr. Kalu was making on basic research, there is a problem with Noma, in my opinion, right now. It's that we don't really quite understand the physiopathology of Noma, nor the causative problem of Noma. In the review that we made, we found 106 microorganisms which were reported to be associated with Noma. What does that tell us? Well, we don't know what is the microorganism which is probably causative, and maybe that's not the point, because maybe there is not a single microorganism. It's the underlying condition that the person is, which is going to facilitate the emergence of a Noma severe form. So I think all of that is entangled together, and I'm reluctant to think that we need to think about there is one thing that we need to do first, but rather trying to make a comprehensive package of what needs to be done. Over.
Thank you very much. Mark, do you have any thoughts if you were to be asked this question?
Yeah, I think I tend to agree, and I think the financial and the awareness aspects are mutually combined. Without more awareness, we won't get more money to research it, and it's symbiotic of each other. And I do think there's an element linked to getting Noma onto the NTD list, because getting Noma onto the NTD list is not going to be a silver bullet. But what it actually might do is actually maybe just raise that awareness, lift that awareness up a little bit. So hopefully that could help us try to bring in those extra financial resources along with the awareness. And that then builds into advocacy strategies as well around this. Because linking back to the first question about prevention, I think we know how to prevent Noma, and it's linked to livelihoods, it's linked to access to healthcare, it's linked to water and sanitation. We know improving these things, all linked to sustainable development goals, that does actually improve the conditions where it prevents Noma occurring. We saw Noma in the Netherlands in World War II during the famine in the Netherlands. And with the change in the socioeconomic conditions, we can actually try to prevent Noma. So that brings into more the advocacy and the political element around prevention. But yeah, I think, and also coming back to, I do tend to agree with Dr. Kalu, and the basic sciences, we need to know more about the pathophysiology, the etiology of this before we can actually target treatments, diagnostics, and knowledge around the disease. So, and it comes back to Professor Gehre in there as well. It's like it's an element of all of this, all has to come together. I think one alone is just not enough to focus on. It's an element of everything.
Okay, and I'd just like to pick up there, and maybe can I just, it's something that Michele mentioned. Michele, you were saying, just because Noma isn't on the NTD list, it doesn't mean it's not considered by the WHO and it's not sort of worked on. But from my perspective, if it is not on that NTD list, it really is a turn-off for grant funders. It's so much easier to say this disease is a recognized NTD that is being taken seriously by the WHO and has been labeled as an NTD. Now, if Noma is not on that list, it kind of causes problems in obtaining funding, especially, and this is what we've seen in snakebite for decades, essentially. So, can you give some thoughts on that, perhaps, and what your thoughts around the funding situation for Noma and how getting onto the NTD list may help?
Yes, I mean, obviously, being on the list would raise awareness and it would facilitate advocacy for research grants, etc. But we have a reality. The reality is that there's been a moratorium that no more diseases will be added to the NTD list until 2023. So what are you going to do until then? We're a group of interested parties from many disciplines, and we all talk to each other, and we're already talking to each other now. And people that are aware of skin NTD activities in their area could start looking for Noma. I think these things aren't going to happen overnight. Today's, I understand, a very big milestone in the field of people interested in Noma. It's a pathway. You mentioned snake bites. I mean, scabies is another recent addition, fairly recent addition to the WHO list of NTDs. They had, you know, more than one approach before they got onto that list. They did many things in terms of raising awareness, advocacy, good documentation of epidemiological research. So it was more, and you know, a lot of, as I say, raising awareness. So there's more than one attack, more than one approach. So I would encourage that we don't focus just getting onto that list. That list will happen. It's already, you've got steps, it's happening. It's already mentioned in the strategic document out this you know, October, that in areas which are co-endemic with other skin NTDs, then include Noma. It's already part of the strategy.
Thank you very much. And I must say, having that goal, that target to get Noma onto the NTD list is a great sort of catalyst to, you know, generate collaborations and you know, those advocacy drives and those collaborations that are required for doing the research once Noma has become, you know, got onto the NTD list. So it's a very inspiring target to achieve. Okay, we have 4 minutes left as far as I'm aware, unless somebody tells me differently very, very quickly. I'll just look at the Q&As, just a quick one. So is it, wow, there aren't that many specific questions. Has anybody got any final thoughts that they would like to say on Noma or even on today? And what do you think the immediate next steps need to be? Kalu, I think you've just unmuted, so would you like to say something?
Yes, very quickly. Again, this has been stated in different terms. I believe that the issue of advocacy has to be, or the term advocacy has to be precisely defined here, or offered alternative definition. The general understanding concept is that when you are talking about advocacy, you're probably talking about speaking to the populace and ways of prevention and so on. But I take a different approach to advocacy here, and that is directing these advocacies to funding agencies, quite frankly, that have been reluctant to recognize this as a damning public health issue. As we've used the word embarrassment, shaming, and so on, and they are absolutely correct. If, for example, you know, big entities like the Anai this year, and I don't intend to call out entities here, they could quickly bump up the status of this disease with respect to the attention it deserves, and we all agree with that. That will make a very big difference. That means that international collaborations could be adequately funded, and there will be that patience on both the side of the funder and the researchers to deliberately design and carry out, you know, researches specifically targeted towards certain areas, be it preventative, basic sciences, or what have you. I think that's really the advocacy we need. The populace already know that there are diseases. The advocacy we need is to sensitize the big pockets or the deep pockets to actually respond to the inquiry need of this disease at this point in time.
Thank you very much, Galli. Unfortunately, we've run out of time. I'd just like to say thank you to all the panelists today. It's been absolutely fascinating, and thank you for your responses. Obviously, next time we do this, and there will be a next time, hopefully, we'll leave a lot more time for this sort of panel session, I hope, so we can have much more dialogue. Now I'm just going to hand over back to Marianne, who's going to close the session for us. Thank you very much.
Okay, well, a very big thank you to Stuart and all the panelists. Thank you so much for these thoughts. and all importantly, some very concrete practical steps for collaboration and advocacy for our agenda going forward. And once again, as we come to the end of our meeting, I'd also like to thank those who spoke earlier on in the day, and of course, everyone who tuned in and joined today. What has been really apparent throughout this meeting, and I'm sure you'll join me in these thoughts, is that Noma is not only the unacceptable face of poverty, and in fact, I believe it was Semyu who summed it up quite candidly in the chat by simply writing, all said and done, how can we justify the existence of Noma? So very well put there. And so not only is tackling Noma a moral imperative, but further than that, what we have heard today is that maybe the time is right, given the oral health resolution, given the NTD roadmap to 2030 and its very powerful paradigm shifts, and given kind of the broader global conversation about sustainable development goals and global health inequality, particularly as starkly highlighted by the COVID-19 pandemic. So bringing all this together, maybe the time is now for a disease like Noma to represent a real touchstone that will catalyze all this rhetorical talk about multi-sectoral collaboration, universal health, etc., into an actual reality. And so, as we've heard today, whether framed in terms of human rights, neglected tropical diseases, oral health and nutrition, or a WASH priority, etc., I do think it's time that it's okay to believe that we can be really bold now and ambitious on the global stage when it comes to Noma. So I really feel that we leave this meeting today, this very first Noma Research Day, with a lot of energy behind us. In a slightly more practical sense, in terms of the research agenda, we've heard all about the priority gaps that need to be filled. And on that level, what each and every one of us can take home and do is to ensure that we communicate and collaborate more with each other, focusing on ongoing and future needs. And quite simply, that comes down to reaching out to somebody you've met today or one of the presenters. Lots of email addresses have been shared, so definitely please do continue to consolidate this network. And then also beyond that, to reach throughout your own networks to bring in perhaps new partners and new colleagues into this community, colleagues from other disciplines or who work in the regions where Noma remains underreported. Another practical step, we would really like you to reserve the date of February the 10th, 2022 for the second annual Noma conference. And we look forward to seeing everyone there again. No doubt February will be here in a blink. And finally, if you can, please give us a few more seconds of your time and fill the post-meeting survey that is about to go out. So on that note, I believe we have run out of time for today's meeting. I don't know about you, I felt it just kind of went in a blink. It was really packed and a wonderful day. Lovely to see so many familiar faces and meet new ones as well. And lots of people tuning in from around the world. So really a fantastic afternoon spent in your company and driving forward the Noma agenda. So on that note, once again, a massive thank you to the organizers at Médecins Sans Frontières, at INEDIS, and all those involved, to our presenters, and to Stuart Ainsworth, who led the roundtable discussion. And I hope to see you all very, very soon. In the meantime, please take care and all the best.